السلام عليكم ورحمة الله وبركاته. اليوم إن شاء الله راح نتكلم عن الأوفيريان سيست. راح ناخذ نوعين، بناخذ الفانكشنال cyst وبناخذ البوليسيستيك ovarian syndrome. So we will start with the functional or the physiological cyst. How they will present. طبعا أول شيء presentation, they are reproductive age, okay, they will come to you and then they have, for example, maybe they are just doing this ultrasound مثلا، يمكن تطالعون السيست موجودة، أو ممكن pain during menses, you will find that they have a cyst. Now, the most common type of cyst found on the reproductive age, you will say it is functional, it is physiological cyst. Now, the prognosis, usually it will resolve by its own, or it can progress, but mostly it will go without treatment. Now, we have two types. We have follicular cyst, and then we have the corpus luteum cyst. Now, in the follicular cyst, as you can see in this picture, the top one, it is very big, right? So it is 4 to 8 centimeter. It occurred during ovulation. It will not burst, so it will accumulate the fluid from the granulosa cell. So they have fluid rich in estrogen, and then usually it will go alone. It's rarely found with the symptoms. And if you do ultrasound, you will find unilocular. That means it is only echogenic center, and you can see in the ultrasound it is only one area. So there is no septation, there is no hemorrhage, there is no calcification, and there is no any other abnormalities. Now, they can only affect the menses by causing pain, or they might alter the length, causing oligo or oligomenorrhea or something like that. Now, it might be tender during examination. The second type of cyst is corpus luteum cyst, or the lutein cyst. It's basically occur because corpus luteum will not regress, so it will progress and then it will not go, and this is more likely to cause symptoms, more likely to cause hemorrhage, and to become large in size, and usually symptomatic, and it is the same unilocular. Okay, so then we have polycystic ovarian syndrome. We will talk about it later, but I just want to mention here that it is a very large ovary that has a multiple cyst, and hyperplasia and hypertrophy of the stroma and the capsule might also be present, and it's like a pearl shape, as in this one, as a necklace. Okay. Now, there is something known as a thecal lutein cyst. So thecal lutein cysts occur because the corpus luteum will be hyperstimulated by a beta HCG during molar pregnancy, twins pregnancy, or ovulation induction agents, and this will cause thecal lutein cysts. Then we have lutoma, which is benign, non-neoplastic tumor. It is basically occur in pregnancy, and it will resolve by its own, and this is how it occurs, and usually without any symptoms, and it's found incidentally. How you can investigate, of course, you want to rule out, because you have a mass, you want to rule out ectopic and all of these things, so you do beta HCG, then you will do ultrasound, and you want to see the Doppler, because you want to see if it is the ovarian blood supply is good or not. So this is all about the benign tumor. Now, they might present, as I mentioned, asymptomatic or symptomatic. If they are symptomatic, they present with stable or unstable states. If they are stable, basically you'll just observe. Okay, you might keep them if they have severe symptoms, and you will put them in PO just in case. In unstable, you will see that from the Doppler will decide whether you want to cut up the cyst only and keep the ovary if the blood supply is good, or if it is not good, then you will remove the ovaries and the cysts. Now, the second topic is about polycystic ovarian syndrome. It is very interesting because it's easy. Now, if you remember this picture, it will help you a lot. So what you will have, the FSH will be low and the LH will be high. Okay, what can cause this problem is the insulin might be high, and this can cause this problem, or if the estrogen is high, it might cause this problem, or if there is family history or uses of other drugs. Now what will happen is the insulin will cause, or the estrogen will cause high level of LH, will affect the theca cell and produce too much androgen, and they come with hirsutism and acne. And then this androgen will cause also obesity, and obesity, as I mentioned previously, it will increase the conversion of androstenedione to estrogen, and this will lead to hyperestrogenic status and increased risk of endometrial hyperplasia. And then you have the inovulation. Now dysfunction in uterine bleeding, you must differentiate between prolactinomas and hyperprolactinemia and the thyroid problems. So this is the symptoms, I've mentioned them already. And then you have the sign. You will see a young girl, she's a reproductive age, and she's having hirsutism, obesity, acanthosis nigricans because of insulin resistance. And investigation, of course, you will investigate for blood glucose, as I mentioned, because insulin is high. So you need to do GT, or oral glucose tolerance test, which is not, it is diagnostic, not screening test. Then you will do hormonal. So you want to check for the testosterone because you have high androgen. You want to check for estrogen, progesterone. Now, estrogen, progesterone, you just check them by the FSH and LH. Okay, and then testosterone, the sex hormone binding globulin, and dehydroepiandrosterone. The ultrasound will show the pear-like shaped, and it is multiple cysts, okay, 20 to 100. Now, the diagnosis, you have to have three. There's a criteria: oligomenorrhea or hyperandrogenism or polycystic on the ultrasound. Now, oligomenorrhea should be 6 months. And then how you can treat the patient: first, you start with the lifestyle modification, like a weight loss and diet, good diet for the diabetes and all of this. And then you will do the also exercising. Now problems, they will present with what? So you treat according to the problem they present. So infertility, for example, you're going to give ovulation induction agent or IVF, because ovulation induction agents, the bad thing is can cause hyperstimulation syndrome in this patient. Now the period usually will be irregular and oligomenorrhea, so you want something to regulate or make it regular by giving OCB. Now OCB, it will act on LH and decrease LH and decrease the problem associated with the testosterone, and it will basically normalize the FSH and LH. The estrogen also. Now there is cyclic progesterone, just to decrease the risk of endometrial hyperplasia because they have unopposed estrogen. And then you have the hirsutism. You want to do oral contraceptive because, as I mentioned, they decrease LH and decrease testosterone, spironolactone, antiandrogens, and all of those things. So I'm gonna show you here. You can see in this they are saying that the oral contraceptive will suppress the LH and decrease circulating estrogen, and this is all about polycystic ovarian syndrome and functional ovarian cyst. And thank you.